engage other stakeholders, such as the city administration and the council, and moving towards actually uh, executing on a plan for if we're going to remain here or if we're going to move to another setting and construct a new facility. So those two options were presented in the presentation that we gave to you guys and to others.
Okay, so I guess at this time, I'll open up the floor for discussion with the board members. Since we've received, information, the feasibility study along with the proposed financing, what does the board want to do in terms of, do we need more information? Because we've gotten plenty of information. Do we want to renovate the existing hospital? Do we want to, move forward with trying to find a location and build a new hospital? So the floor is open for discussion.
Hey there, this is Alex Fisher. Do we have any input from Metro Nashville and whether or not they have a, I don't know if position is the right word, but insight or opinion on the best path forward? Not saying that that's what we necessarily should do, but I'm just wondering if there's any, if Metro Nashville has a position regarding this.
Well, so far, what we've done is make a presentation to all parties. It was in the form of a presentation. And so before we would start to move in that direction, as I stated, we would need to know what our board position is on moving to the next step. The board gave us only authority to go and collect the information and present the options.
Got it. Okay. I just want to throw this out there, of course, for other board members to chime in. Again, this is Alex Fisher. Would it make sense to take our options to Metro Nashville and get feedback? Again, they're not the decision makers, but as you know, they'll be a big part of the financials. So I think it might be helpful to know any input from the Metro Nashville side before the board issues a final directive, or at least that's information that I'd like to have. I'm open to hear if other board members think that's relevant or not.
I would like to know what are you defining as Metro Nashville?
Sorry. Yeah, that's a good question. So probably the mayor's office, because that's more efficient. And again, I'm just thinking out loud, the mayor's office rather than, you can't really efficiently, nor would it really be appropriate to take something in these stages in front of the whole Metro Council. But to the extent that funding, which will be a part of our decision making for what we do next in terms of where the building of the hospital should be, that part of that funding is coming from Metro Nashville government, which will be approved by Metro Council and I guess approved or given its blessing by the mayor's office. I think it might be useful information to have some insight as to what at least some of those players who have control over the financing think of the different options. That's information I'd like to assess along with everything else. And again, I don't want to hog all our time here, so I'd like to know what other board members think in terms of what other information they'd like to have, or if that's not really relevant in terms of deciding what to do next.
Yeah, this is Ranga, and I think I agree with Alex. I wasn't at the presentation to the mayor and the team. Just getting a sense of how much support there is in principle to the idea of even exploring. We're not even talking about the specifics because that's going to follow later. But it just seems to me that this is going to be quite an undertaking once we go down this path. And it just seems to me that if we can get some of our stakeholders lined up in principle for the idea of exploring, it might make the path easier. So in that sense, I agree with Alex about considering the possibility.
Dr. Webb, this is Dr. Burrow. Correct me if I'm not wrong about something. It seems like, I don't know, when this first came up, I guess a year or so ago, when we were going over just what the options were, we started off with the renovation of the current building, and it seemed that that was prohibitive due to the status of the contract. Do I remember something like that?
Well, yes, that was a part of the presentation. The presentation currently has both options in it. And my position right now is that I haven't gotten a clear understanding from the board as to whether or not your choice is to pursue existing renovation of the building or to pursue a new facility. So I think that would be the first point of clarification.
Okay.
I believe this is oh, I'm sorry. Go ahead.
Joe.
This is a huge opportunity for us to make a big difference in the hospital's life and in Meharry's life, and more importantly, in our patients' lives. If I recall the data correctly, we need to get the mayor's approval. The mayor has expertise in real estate transactions, so we need to ensure that the mayor, I don't know, when you say you've met with the mayor's office and did a presentation, I didn't catch if that included the mayor.
Yes.
So
No, it was with the mayor. He actually came here to the hospital with
okay,
his.
great.
Yes.
And then I believe that the rent payments that were in the pro forma that we currently pay, the lease payments, would be redirected to pay the loan back that we found private funding. So no money would come out of Metro's coffers for the construction and project of it. So it will be up and running without Metro dollars. We would still use our subsidy as opposed to paying a lease payment. We would be paying a lease to own payment. And after the project is paid off, then I guess the hospital authority owns the building, but likewise, that pretty much reverts to Metro. So I thought we had agreed that we were not going to throw good money after bad, and we were going to pursue Metro to find land that we found feasible to build this building on. And I know Metro Center was kind of the last one we kind of landed on. So I thought that's where we had landed, is we were going to build a new facility designed for today's standards and future standards that would better meet the needs of the city, not only for the indigent, but the commercial paying clients as well, patients as well.
And Joel, this is Alex Fisher. I'm with you. I recall that being our conversation. The board members, after reviewing the feasibility study, that the numbers as presented to us looked like it was a better financial decision to look at some of the land that Metro currently owned versus the cost of renovations in the current location. Question for our executive team: has that, as part of the presentation to the mayor, was that feasibility study that us board members have looked at, was that part of the presentation to the mayor's office?
That was part of the presentation. Now, what you gave us was the go ahead to investigate opportunities. You did not give us the directive to go, to the mayor's office and proceed with exploring financing or anything else. So that's where we are. I mean, we can do that. We just need you, because the first thing that's going to get asked of us is, what is the board saying? What does the board think? What does the board want to do? So I need clear direction from you, board, on what you want us to do next. We can execute on it, but I need that clarification, because what's in the minutes is stated as explore opportunities. We've done that.
Yeah.
Okay, so let me just say this. Some of the initiatives that we have, they're originated in the mayor's office. Some are initiated by Metro Council as they represent their constituents. We need both, okay? Because it's going to take at least, 5 years to design, construct, and to occupy a new space. So we need to keep that in mind as well.
This is Bonnie. I wanted to say that as Joel summarized it, that's my memory of everything. And as Dr. Webb has said, the one thing we haven't done is, as a board, committed to that and committed to pursuing that option as I remember it. I remember it, we left it just up in the air. And so the ball has to be in somebody's court. Are we going to say, yes, we approve of taking this forward, taking this to the mayor's office, pursuing this? We can't just keep kicking the can around.
Okay,
This
so
is Alex.
well, let me just say this. This is Dr. Fagans. We need to, as a board, approve the committee, Dr. Webb and his team, taking, that information to the mayor's office.
And once we're done discussing, I'm happy to make a motion. I think Alex was going to say something.
Yes, Alex, go ahead.
No, that's all right. Right in line with what you guys are talking about. I think that's absolutely the next step, since I think the 3 locations we were considering, other than staying where the hospital is currently, are on Metro-owned land. I think that's the very logical next step that we can, that's the next place we need to go if we're going to pursue one of those options, is to make sure that works for Metro. So Joel, I'll let you make a motion if you want to now.
Okay, so Joe, before you make that motion, so this will be an option to pursue a new facility that should be taken to the mayor's office and Metro Council.
So this is Bonnie. Are we not going to state a preference that we have as a result of seeing these presentations? It seemed to me like the most feasible and the best option as presented to us was the one out by Metro Center. To go back and present the other 2, which had serious problems, it seems to me like it would be better to just take one option to them. But maybe I'm misunderstanding the process here.
Bonnie and the rest of the board, I think we just need to let the mayor guide us on that decision, and not go with a preference, but just to present to them, that we want an option to pursue a new facility, and let the city decide where that location would be.
Right, they may have better locations than we've already looked at, because they are going through their real estate portfolio and looking at sites that would be due for purposeful change. If they ask us, we'll tell them that's what we have researched and come up with.
Okay.
So Joe, you want to make a motion?
Yes, Madam Chairman, I would say that I make a motion that the board approve the executive team to pursue building a new hospital with the mayor and council to ascertain any additional information before we proceed with engaging architects and engineers.
Okay, that's good. Can I get a second?
I'll second, Bonnie.
Thank you, Bonnie. Any further discussions? Okay, if no discussion, all ayes.
Aye.
Hi, Joel.
Aye.
Hi, Ranga.
Hi, Alex.
Any nays or abstains? Hearing no nays or abstentions, the motion carries. All right, now we'll move on to new business. Is there any new business? All right, no new business. So our next, we'll move on to the minutes. So, did somebody say something? Okay, so our next order of business would be to approve the hospital authority minutes from the November 19th, 2020 meeting. Are there any additions or corrections to the minutes of the November 19th Hospital Authority Board meeting? Okay, there being no additions or corrections, I'd like to entertain a motion to approve in a second the minutes of the November 19th Hospital Authority Board meeting.
Motion to
Motion.
approve.
Second.
All right, any further discussions? Hearing no discussions, all ayes.
Aye, Bonnie.
Aye.
Hi, Rhonda.
Hi, Joel.
Aye, Burley.
Okay. Any nays or abstains? Hearing no nays or abstentions, the motion carries. Okay, moving on to the CEO report. Dr. Webb, you have the floor.
Thank you, Madam Chair. I sent out a document to the board electronically on the updates. But I do want to just briefly run through them, starting with this week's virtual town hall meeting, which we were able to showcase the hospital many highlights and provide a community update. We featured a pre-recorded segment with live Q&A with the Metro Hospital Authority Board Chair, Dr. Fagans, and the executive team leaders. And the town hall was live on Facebook and YouTube. You have a link in your electronic copy that will allow you to go and capture that information and review it, look at it if you choose to. So you can still do that. Moving on, the Meharry PSA agreement. On December 31st, we submitted a draft of the PSA to the mediator and between Meharry and Nashville General to the mediator. And we did receive back on January 27th a modified draft of that version of that. And so we're in the process of reviewing that, and we'll be meeting with a mediator following that review. So that's forthcoming. We'll be meeting tomorrow morning ourselves to go over the feedback that we got in the redlined copy. Our clinic volume for the year has been strong. For the full year of 2020, we had right at 36,000 clinic visits, up 11% over last year. The key areas of growth were the urology clinic on Charlotte, podiatry here at the campus, and the family medicine clinic at Charlotte. Our CHIN organization was awarded another $100,000 grant from the Metro Nashville Special Fund administered by the United Way. And that fund is to provide rent, mortgage, and utility assistance to families. And so this is the second of those grants that we've received, and we commend the CHIN group for the work that they're doing. As of January 26th, we've administered more than 800 vaccinations to our staff. That includes 379 people who received both doses of the Pfizer and 80 people who've received the Moderna vaccine. This Friday, we'll be administering vaccinations to our existing patients, those that are age 75 and older, as indicated and approved by the state of Tennessee's vaccine distribution plan. Just an announcement on one of our programs here, Our Kids Soup Sunday. This year, our kids introduced a creative campaign because of the pandemic to Soup Sunday, to their Soup Sunday fundraiser, Soup Sunday Home Style. You have a link in your email that will allow you to be able to go in and purchase and participate and support this endeavor, which over the last 25 years, they've raised roughly $1.5 million for our kids. It is one of the programs of Nashville General, and we really do appreciate the great work that they do. In December, we had media here to cover our administration of our first vaccination. And you'll see here we at Channel 5, PBS, Nashville Voice, Nashville Post, and the Tennessean all were here to cover that. And we also were featured in the December 27th Titans versus Packers game. Some of our Nashville General Hospital staff was featured on that NBC Sports Frontline Heroes as a spotlight. And that is a quick summary of the CEO's report. You do have a copy of that in your inbox. I'm happy to answer any questions or any additional information that you might want me to cover.
So, thank you, Dr. Webb. This is Ranga. I just had a question about the 1/3 of the staff who expressed a preference not to be vaccinated. Can you just say something more about what that means for even the patients getting vaccinated and what is being done to decrease that number or that percentage?
Yeah, I'm going to ask Dr. Bullock to respond to that. She's much more closer to that issue, and I can give a high-level summary, but I would prefer that she give a little more internal information on that if she's available.
Sure. Ranga, you're asking specifically about the third of our employees that declined. Is that correct? Or the third?
That's right. That's right. That's from the
Yeah.
update. Correct.
So those numbers are from essentially before we knew how much vaccine and when we were getting vaccine, we kind of took a general survey of who would be willing to accept and who would not be willing to accept just in our entire NGH staff and employee pool. Obviously, that was before Pfizer had completely rolled out, before Moderna had completely rolled out. So there was a lot of hesitancy. As we kind of continued to roll this out, we have seen an extensive number of people change their minds. We are continuing employee and staff vaccinations as well. We completed our first complete rounds last week in terms of first and second doses, but we're going to continue on a weekly basis. We're noticing more and more employees coming forward, changing their minds. Same thing happened on the resident side as well. We didn't have a whole lot of declinations on the attending physician side, but we did have a whole lot of declinations initially on the resident side. And as they saw many of their colleagues getting it, change their mind. The first couple days and weeks of actual vaccinations were a little bit of a cluster just because we had so many people tell us no, and then they changed their minds and, were showing up day of vaccination saying, well, now I want it. So it created a little bit of a cluster, but we got it all worked out, and we're going to continue to do that, and continue to offer as people get more information. And I think it's just, it's the newness of the vaccine, it's the newness of the technology, and people will continue to receive the vaccine as it becomes more and more information becomes available.
Thank you.
Thank you, Dr. Bullock. And Ranga, that was an excellent question. Appreciate your posing that. One other thing I wanted to just mention is that the clinic volume that I mentioned at 36,000, the goal for this year, Dorothy, I believe is to achieve 40,000 visits in the clinics. Is that correct? Dorothy Bennett?
Yes, sir, that is correct. It's almost 41.
Okay. All right. We're on track. Looking forward, we're on track to achieve that.
We are. We had over 20,000 for the first 6 months of the year. So we should have no problem meeting that.
Okay, thank you.
Mm-hmm.
Any other questions for me? Thank you.
Okay, so now we'll move on to the compliance report. Groves, you have the floor.
Thank you, Madam Chair. So the compliance report is a year-end report for 2020. You should have it in your packet. I'm not necessarily going to go over all of in depth every single slide, but it does include the number of compliance cases opened and closed for 2020, as well as the policies and procedures that were reviewed and updated for 2020. Those are not policies that are for the board's approval. Those are just to let you know which policies and procedures went through the full approval process internally at the hospital for 2020. The report also includes some points of the education and training that the compliance division did for staff last year. You'll see that listed there. And some compliance updates related to a new regulation that went into effect on January 1st, which is the Price Transparency Act. We are in full compliance with that. And in fact, I would like to give kudos to our revenue cycle and marketing division. Our price transparency page was up and running at midnight on January 1st. CMS had indicated that they would start auditing hospitals at midnight on January 1st, and ours was up and fully functioning at that time. There were several hospitals here locally that did not have their pages up by January 1st. And in fact, there were some that took at least a week to get theirs updated. So those areas did an excellent job on getting that ready and in place. In your packet, you will also see, I have included, and I do apologize that it has made the board packet so lengthy, but I have included 2 articles for the board's education that I felt was timely and something that the board, as a governing body of the hospital, would be interested in reviewing. I'm not going to go over it tonight. You can certainly review it and let me know if you have any questions at the next board meeting. I have also included in your packet the 2020 HIPAA risk assessment. That is required, an annual risk assessment that is required under the HIPAA privacy and security rules with the Office of Civil Rights. So we've conducted that, and we are working through any areas that we need to address, and we are meeting internally to address those. And I will entertain any questions that the board might have.
Okay, thank you, Julie. So if there's no questions, I'll entertain a motion to approve in a second.
So moved, Ranga.
Second. Can I get a second?
Second, Bonnie.
Okay, thank you. Any further discussions? Okay, hearing no discussions, all ayes.
Aye, man.
Aye, Bonnie.
Hi, Alex.
Aye, Ranga.
Okay, any nays or abstains? Hearing no nays or abstentions, the motion carries. So now we will move on to the quality report. Phillips, you have the floor.
Good evening, Madam Chair, members of the board. Actually, this month is going to be this submission of the quality plan for your approval. It should have been included in your board packet. It has been through the Quality Management Committee on the 19th of this month and approved, as well as the Med Executive Committee, of which it was approved on the 21st. This is one of the annual plans that's submitted for board review and approval. I too added 11 pages to your board packet. My apologies, but that's one of those things we have to do. So if you have any questions, I'm here to answer the questions planned tonight. If not, it's just submitted for your review and approval.
Any questions regarding the quality report? All right, hearing no questions, I'll entertain a motion to approve in a second. Can I get a motion to approve?
Move approval, Manson.
Second, Sanders.
Okay. Any further discussions? No further discussions, all ayes.
Aye.
Hi, Ranga.
Hi,
Joel.
Bonnie.
Hi, Burley.
Any nays or abstains? Hearing no nays or abstention, the motion carries. Okay, we'll move on to the medical staff credentials report for November and December.
Okay, let's see what we got here. Let's take a look. We had several appointments to provisional status. Starting off with the Department of Surgery, there was a Ferris Gebery. Then there was a Kelsey Taylor with Family and Community Medicine. Andrew Marshall, MD for the Emergency Department. And Brian Morgan, CRNA for anesthesia. These were all provisional appointments with no identified issues. In terms of those individuals moving from a provisional to the active staff, there was Eldo Frezza, Frezza, once again to the Department of Surgery. Ryan Johnson, Emergency Medicine, provisional to active staff.
Cameron,
You need to take her so she'll quit walking.
sorry.
Okay. Christopher White to internal medicine, in internal medicine. These are provisional to active. And under reappointments, there was Dr. Rosalina Muckle in internal medicine, Dr. Lavette Johnson, internal medicine, and Brian Unsel in the Department of Radiology. And we had one resignation, Secure Karen Nahum, in the Department of Emergency Medicine. No other issues were identified with any of these individuals, and I move to have them approved.
All right, thank you, Dr. Burley. Are there any questions regarding the medical staff credentials report? All right, hearing no questions, I will entertain a motion to approve in a second.
Second, Joel.
Okay, all right, any further discussions?
Who made the first motion?
Dr. Burley did, apparently.
Yep, I did.
Thank you.
I didn't hear it at first. Okay, thanks. And Joel made the second.
Yes.
So any discussions? Okay, no discussions, all ayes.
Aye.
Hi,
Aye.
Aye.
Hi, Joel.
Any nays or abstains? Okay, hearing no nays or abstentions, the motion carries. We'll move on to the finance report for November financials. Nair, you have the floor.
Thank you, Madam Chairman. I'm going to share my screen here and go over a couple of things. We were unable to have a quorum for finance today, although my members were available for 4:30, so I do appreciate them attending, but I'm going to have to go over some detail here that we typically wouldn't cover in the board meeting. I'm going to share my screen and see if that works for you guys. Let's see that. 1 second. That's not what I want you guys to see. Hold on 1 second.
Drag it over to the other side.
Now I'm out of this. Okay, folks, I apologize. I am not able to share my screen right now, but you should have the presentations with you at hand. I just first wanted to say that we had hoped to have the audit partners present tonight. Spoiler alert, the audit is complete. It is a clean, unmodified opinion. We did have to schedule a special board meeting on February 9th that you should have gotten an invitation for. I think it'll be pretty without drama, and I don't want to presage anything that the partners will say, but the partners on our engagement were simply not available today. They were at another client that had a hard close. So it's good news, but we're going to have to wait another 9 or 10 days before we can officially bless the audit. But it's good news. Second, in your packet, there is an alternate care site or a COVID report. It's just a small spreadsheet that you can see there. We had a lot of questions from council members, others in the community about what happened, where did we get that $10.2 million? So on this sheet, you can see the dates and the amounts that we received, the $375,459, and then the big one in mid-June for $9.4 million. And then you can see how some of it has been consumed thus far. There was about $2.6 million of net revenue impact that we drew against for the period in February through June of 2020. And then you can see what we've drawn in fiscal year 21. So total revenue impacts thus far, $5.5 million of eligible reimbursable costs. And then you also see the expense offsets below. So protective equipment, any replacement or repairs or other equipment in the hospital setting, including moving endoscopy from the second floor to the third floor so the ACS people could take it. And then labor costs, direct labor costs associated with either COVID checkers working the front of the house to screen patients and visitors, plus the differentials that we put in place to retain key clinical staff, and some retention payments that were made to keep clinical staff, some ancillary staff such as respiratory. That's the other $1.7 million that have been drawn through November. So in total, through November close, we've drawn 7.2 million of the 10.2, and there's a balance remaining now, restricted funds. So it's a liability on our balance sheet of just slightly more than $3 million remaining. We have until June 30th of 2021 to fully expend those funds. And that's just an update. The alternate care site, and Mark may want to talk about it briefly. We did have a flood on the 8th floor. I think Mark, would you just give a status on it if you don't mind?
Bruce, I don't mind. So on Christmas Day, we had a flood on the 8th floor of the ACS, like Bruce shared. What happened was it froze up. The pressure on the roof and the water supply that we were getting didn't have the correct temperature like they thought it would. And the pressure built up, and the pipes that they send hot water through actually froze and cracked. And by the time we made it up there on our rounds and facility, the floor was flooded. So since then, TEMA has come in and they have repaired the heating system on the floor. They've renovated or abated the drywall and the floor that needed to be repaired, and they've repaired that. Where we're at currently is they're actually looking to make sure that, because what I believe that they did was they went off the original drawings for the mechanical engineering part of the system, opposed to actually doing checking the pressure and the temperature that we're getting from Harry boilers. So now they're actually diagnosing that to make sure that when they repair it, that they actually have the right specifications. So that's currently where we're at. That's a quick update. and I'll entertain any questions that you may have.
Thank you, Mark. So I just wanted to, so the ACS has not been opened here, nor has the one in Memphis been opened, and certainly hopeful that it will not have to open. And I think the major issue that the state is facing, just like we're facing in hospitals around Tennessee, is we could open the beds, but the availability of staff to provide care to those beds is probably the challenge, and part of the reason why the state has not yet acted to open either location. So that's just an update. If there are any questions, myself, I got Jerry in the back here. That's why we're in masks, sorry. We can certainly answer any questions that you may have about the status and what we have left of the 10.2. And then in no questions, in the interest of moving forward, we provided this month, in 2021 fiscal year, and we're getting ready to put a budget out for 2022 request to Metro in February timeframe. We did not receive any capital in 2021. I know it was a very difficult year for Metro government. They've had pandemic effects as well. But we have some extreme critical capital needs in this hospital. We requested a little over $7 million in the budget 2021. And as I said, we got zero. But there were some things that were much more critical and have become even more critical as the year has gone forward. So we're bringing this to the board's attention. These are ones that the executive team put together, not to diminish the other $4 or $5 million of capital that we had on the list, but these are ones that we find extremely critical. They're both clinical and they're operations in the hospital. But take a little look here. The thought is if we could at least get the board's support, maybe endorsement, we plan to push really hard with Metro Council to at least throw us some money for some of these critical items in the next 2 4% rounds when the council actually gives out within the year, they actually give out some capital. We've been the beneficiary of that in the past, but not probably in the last 12 months or so. So just if you take a quick look on this list, we've got 2 orthopods working here and a podiatrist, and we do not have a functional fracture table. So they have to make do as best they can. It's about a $88,000, $90,000 item into one of our ORs, and it's a serious need for a growing service that we provide at the hospital. There's 400,000 on here. That's probably a little less than we need for the monitors in the hospital. Our monitoring systems through most of the hospital are approaching 9 years old, and they're ending support for that system. So we're looking hard, and I know it's really hard when we don't know where we're going to be in 4 years or 6 years, because the cabling costs for setting up a new monitoring system are substantial and would be lost if we picked up and moved in 4, 5, 6 years. So we've sort of gone about this. We've deferred it for a couple of years because we didn't know if the hospital was in fact going to move. But we're getting to sort of a critical point with our monitoring systems within the ER. And when we transport a patient to the ICU or to the floors, now we have very active cath lab and interventional radiology. We need those monitors to travel with the patients post-procedure.
I have a question.
Go ahead.
These seem like, for example, your fracture table that you went over, these seem to be items, all of these seem to be things that we need to have really to stay in business or to be operating at as a hospital. Is it any way that we can determine, like the fracture table is going to make us money, right?
It will make us some money, and it will keep us from having a bad patient outcome that could cost us a lot of money.
Are all these things have the potential of generating revenue?
Well, an air handler, there's 2 air handlers on here, and there's a electric, a switch gear. Well, those are just base requirements for this hospital to continue to operate. So they don't make us money, but they're required. And don't forget, and she didn't say it in our quality meeting or presentation, but this is a Joint Commission window year for this hospital. So some of these things are more critical than they were even a year ago. But
So
yes,
you want our endorsement of these particular items, or do you want authorization to go ahead and do it, to buy it?
we don't have the cash to spend on them, unfortunately, but we do want board members' support as we approach council members. We may need to reach out to you to ask to help reach out to a friendly council person who would sponsor some of these. We've had a CT on our 4% for probably as long as I've been here. And our CT unit here, of which we only have one, has been down twice, I think, in the last week, which causes us to go on diversion and doesn't give us the ability to diagnose. You know, that's the standard of care, is to take that chest CT for patients with COVID or COVID symptoms. That's as clear a diagnostic tool as anything else while you're waiting on a lab test to come back. So we would like to get a second CT, a refurb. We're not even talking about a brand new unit, but a refurb, something under $500,000. We've got the space for it. But otherwise, we're totally dependent on, I think, a 7 or 8 year CT machine that has probably gone way past what its useful scan life would normally be. It's been very reliable, well managed by our staff. And then, as I said, our cath lab has gotten really busy with Dr. Akama and Dr. Thanawala. You got two very busy, I don't want to say type A, but close to it, personalities, and having them fight over the availability of the cath lab on certain days. And they don't do it, they do it professionally, but that's inappropriate for a hospital like this. We could do a lot of those cases in a small angio suite right down the hall. And that's what's also on this list at about $350,000, so that those doctors could operate at the same time with the support staff and get their patients properly cared for.
And to Mr. Manson's question, those are major revenues.
Yes, yes, that is very major revenue.
So you've done an ROI on all of these things, obviously, that you're going to present to them, right?
What you do, Bonnie, I tell you, an ROI on a piece of equipment that you already have, like, so for instance.
So yeah, replacing how often it breaks down and the repair costs.
Yeah, you know, the CT machine, you know, we're a service safety net hospital. So
right.
CT unit, I'm probably not going to get more scans necessarily out of it. I'm going to be able to diagnose patients in real time because most of our work happens in the daytime here at Nashville General, but I won't have to go on diversion regularly, which we've done several times just in the last couple of months because of CT.
Now that is a loss of business when you have to go on diversion.
Yeah, yeah.
But loss of confidence too, because the ambulances quit coming.
Yeah.
Yes, I know.
So we go through ROI, Dr. Slovis, we are so far behind the 8 ball on capital. Our depreciation is about $5 million a year. Just basic financial measure is that you should spend on capital what your depreciation is annually, or you're not replacing your plant quickly enough. Our average age of plant is approaching 17 years. Even BBB rated hospitals would have 8 to 10 year average life of assets. So we're way, way, way behind. We make good as best we can, but it's getting to be a critical point. And like I said, it's Joint Commission year. We've got other smaller issues that we have to take care of as well. So
is there any way we can lease any of this equipment? Is that an option?
We're looking at some of that too, Richard. You know, like imaging equipment can be, it's a per click basis, so it increases your operating cost, but we're sensitive to that. I know Mark's working on some leasing possibilities for imaging equipment, not for these necessarily, but for some others like the Clarksville Highway location that we'd like to open a small imaging center there, make it freestanding so they don't have to have hospital pricing, so that we'd have another opportunity there in the marketplace. So we have, and Mark has worked on several of those. We worked on them both. But these, I mean, I don't think a fracture table or switch gear or monitors are probably likely to be, you know, eligible for a per use type arrangement, possibly the angio or the CT, but they're refurbs. And so usually you see those with brand new equipment.
Well, we acknowledge, I think as a board, we can acknowledge these things are necessary. What do you want us to do? You want us to either by way of motion or some other action, endorse these items as necessary for the continued operation of this facility so that we can maintain a level of patient care that's required.
Very eloquently stated, Mr. Manson.
I probably can't restate it, but I hope somebody got it down. But anyway, I'll entertain the motion of what I just said if somebody took it down. But I think it's very, very necessary.
I'd second your motion, Mr. Manson.
Thank you.
Don, can I get clarity as to what the motion is?
No.
Mr. Manson.
Yes. The motion was I acknowledge the need for the items that have been submitted to us in this capital plan as being necessary for the maintenance of patient care, for excellent patient care, and that we sort of endorse this as a board. I think that's what I said, Don.
I'm not sure, but my recording will state it for me when I go back to do the minutes.
Okay,
So
but that's the gist. That is the gist of it. So I'm sure she got it down.
Thank you.
Okay, so we have a motion and a second. Are there any further discussions?
The one question I have is on the CT machine, because it is such a critical asset for COVID diagnosis. Can that not be put against the COVID money?
Joel, it could be put against it, and it's a possibility, but it's, at the rate we're going, we believe the $3 million will be absorbed before we get to June 30th. So in a roundabout way, it would probably end up getting paid out of operating funds anyway. And we're really, really tight for cash this year just because, you'll hear briefly, nursing contract labor rates have gone absolutely through the roof. Dr. Slovis probably knows at Vanderbilt, they're experiencing the same. Our rates for a critical care nurse have gone from $73 an hour to $120 an hour. And others are paying more than that. So, and we're happy to have them because the alternative is that Veronica and Dr. Bullock have to go on diversion and squeeze down the ICU from 12 beds to 7 beds. And then we have patients holding in the ER. I mean, none of those are palatable. And we hate to have to pay those rates, but we have to keep those floors and critical care areas staffed. So our costs are rising rapidly, and I don't know what to tell you it'll look like by the time we get to budget. That's a challenge that my finance team and I have now. How do we project what the costs are for supplies and equipment that are already in short order, primarily distribution related? And then what about the staffing costs going forward? We know what we're paying our staff, but we don't know what we're going to have to pay for that contract labor going forward. It is a moving target. And I do hope that this disease is starting to abate, or maybe we're starting to make some headway as a nation, because we need to get back to some normalcy. It's also affecting our outpatient revenue at the hospital. Although our inpatient is up, our emergency room is down in terms of visits. Low acuity patients, low acuity operative procedures are down because patients are just deferring rather than put themselves at risk. So that's usually good paying money for us. The clinics have been doing very well. So they're up. And so eventually I think patients are going to get confidence and come back. But that's sort of the cross we bear, Joel. So yes, it's eligible. And we talked to the DRS people early on. They thought that was clever, that we could make that CT because it's a very important diagnostic tool for COVID, and adding a second one, very much eligible. Just will we have the money for it? And which vendors do I tell no when we spend $500,000 on a CT machine? Because we're about 75 days out right now on payables.
So this is Ranga. I have a quick question. So about the motion that is for vote right now, Bruce, does that meet what you're asking for?
Yes, I'm really, Ranga, I'm looking for support from board members so that if you get a call or if you have a friendly councilman or if we need some support, that we could just reach out to you guys and I could point them to an expression of support that came from our board for these critical items.
Thank you.
Any other discussions? Okay, so if no discussions, all ayes.
Aye, Joel.
Aye, Ranga.
Hi, Burley.
Aye, Manson.
Hi, Fisher.
Hi, Bonnie.
Okay, so any nays or abstains? Hearing no nays or abstentions, the motion carries. All right, are there any questions regarding the finance report?
Dr. Fagans,
Yes,
we still have to do our financials. One more.
okay, I'm sorry, go ahead.
Right. Okay, we're gonna go quick. This is November, by the way. We did not close December. We didn't want to bring you 2 months. We're closing December right now. I know it's January, but we're trying to get done with the audit. So for the month of November, we're talking about our patient volumes were pretty static compared to October, 167 admissions, 174 OBS admissions, and our census was just below 30, which is a little bit above budget, but it was because our length of stay is up substantially, and it's staying up because we have some long stay, primarily COVID patients that are driving up acuity in the hospital and driving up our lengths of stay for our patients. Emergency visits flat at about a little over 2,050. That's consistent. We used to run consistent 2,600. It's been down since really the COVID pandemic started. Emergency admissions, a little below budget, but comparable to last month. Clinic visits in November were down, but that was only because of the holidays, the holiday week that we had. Surgery and so inpatient and outpatient surgeries were both down compared to budget and prior month. But again, it was the first holiday month, and that's reasonably expected for us. Cardiac cath lab is up substantially. It's up even much more last month and a half. You'll see on the next reports. Deliveries were down in the month, and that's unusual because we've been up most of the year. So that was a brief break in the action for deliveries. So overall, volumes were relatively static. Go to the income statement on the next page, and you'll see total. So our gross patient revenues were a little over 21.1 million, about 6% below the budget for gross revenue. Net revenues from patients, 3.75 million, about 6% below budget due to the slightly lower volumes, particularly the ER and outpatient areas. We did have a positive number in other revenue, and most of that is about $300,000 of COVID revenue impacts that we were able to draw down. And so all in, we had the subsidy of 3.59 from the city. So our total revenues for the month were just above 8.9 million, about $160,000 ahead of budget. Then you get to sort of the expense side of the equation. Salaries are up. They're up substantially in our operation here. And you can see contract labor was almost 260,000 above budget. Our supplies are up. You know, when you get into higher cost operating areas like cath lab and interventional radiology, those numbers are going to start going up, and we expected it. the revenues will start going up with it as well. Collections will go up. It's just a timing issue for us right now. Those are sort of the big impacts for the month from a supply, from an expense standpoint. We missed budget by about 600,000 on the expense side. And so even though our revenues were 160 better than budget, our expenses were 600,000 higher than budget in November. And so we suffered a $338,000 operating loss compared to a budgeted profit of $102,000. And then we have the balance sheet behind. And the only thing that's really worth noting probably is in the liability side, you can see the COVID grant dollars out there waiting for us, still to be drawn. And I think, I'm going to quote Jerry here, I think we're going to draw about 450,000 in December. I mean, we're relatively close, so we do know what that entry is going to be for December. So that's the financial statements for the month. And I'm sorry this had to be so long, but we missed finance, or we would have given you guys the abbreviated version. I do have Ms. Crowley's revenue report, and November and December, you guys really should hear those reports. If you don't mind, Madam Chairman, just a few minutes.
Yeah, sure.
Okay. Christine, you take the chair.
All right, thank you. And I'll be quick and I'll focus on December. The cash for November was down from the previous month, but still way above budget. And we had a record collection month for the month of December there. At yes, over 5.3. All the payers were paying. It seems that they were in the holiday spirit, but Centene was giving us extra gifts. In the prior couple of months, they had started auditing some ICUs and doing ICU day downgrades. So I worked with them at a higher level, and they have paid those and are working on getting that process streamlined so we don't have those problems going forward. And the next slide is our unbilled. You can see we're nice and steady, keeping it down below goal. Starting with next month's report, you'll see that we're going to take that benchmark down, make it a little tighter for us. We're going to set that at 6 with a stretch goal of 5. And back in April, we showed that we could get below 4 days. So we're really pushing to get the coding within that bar, as well as our providers and departments and everybody working together to get those claims out the door quicker. The next slide is our new denials, and they're over our goal line, which is negative. And we're having the same issues most other hospitals out there are having. I network with them frequently, and Parallon networks with us frequently on their hospitals and what they're doing. The topmost ones continue to be authorizations, and that's nationwide. We have had an uptick in the last couple of months in inpatient versus observation status level. A couple of years ago, that was a big problem for us. Jason Winston got it under control, and the providers, it's like an arm wrestle. So we are determined to win this one. And we have got those down so far this month. So hopefully we'll show a very positive trend next month. About 31.3% of our denials are related to authorizations. The next slide is our accounts receivable over 90. Our goal is to maintain under 25%. And last month we were at 27 and 25. We're doing pretty close to our goal. We know we can do better. Because those numbers naturally go up and down from month to month, I look at it for 3-month periods just to see how we're really trending in the bigger picture. And if we look at those in quarters going backwards there, currently we're running about 22.9%, which is very good. Prior to that, we were 24.6. Prior to that, the quarters before that were about 31%. So at the long picture over the year, we're doing better and continuing to improve that. When we get our unbilled down, naturally that creates the AR to be heavier on the front side. And the next slide is our professional billing. We hired about a year ago, Crystal Benz, who has a lot of experience in coding and revenue and billing. And she has been working on the professional side, ensuring that we're capturing all charges that we can, that documentation is supportive for medical necessity, and that all the claims are being billed timely and the reimbursement is coming through. So we're seeing continued improvement in that area as well. And if you look at the second part of that where it says denied claims, there's two big bumps there for the prior year. If we took that out, we'd have a better picture in our trend line. Right now, the trend line suggests that we're just doing an enormous improvement. We are doing good, but if we take those two out, it flattens that out. So next month, what I'll do is present that two different ways so that we can see, taking out those 2 months where we had new providers, where we truly are from month to month. And the last one is the aging. We ticked up a little bit, but still in pretty good position there. And Julie already spoke to price transparency effective January 1. There's two key provisions. We are considering, go ahead. Is that a question? Okay. We have two key provisions to meet, which we believe we've done very good at. We test drive it, and we do have a price estimator tool that was developed by Amira, one of our staff. And it's a real nice way to get your estimate if you have insurance particularly, and to estimate what your portion is going to be. And even though this seems to be kind of a hassle for us to have to do this year, we're looking at it from a positive standpoint. Because we have patients will ask for that price transparency in two different ways. Their questions will come through an email or through a phone number that we have on that page. And we can track and trend those, and we can even follow up with them from a kind of a marketing perspective to see if they got the information they needed, if we can help them further, and kind of keep our name out there with new patients. Any questions?
Okay, so if there are no questions, I would like to entertain a motion to approve in a second the finance report.
I do have one question for Bruce.
Yes.
Okay.
Bruce, in looking at the numbers, it looks like revenue collection and accounts receivable and all that is working really well. Very thankful for that. On the expense side, I guess my antennas kind of rise up when I hear we're going to run through all the COVID money and accounts payable is climbing as well. Do we have a plan B to offset our rise in expenses so that we don't exceed the monies given us or collected by us by the end of the year? Because we don't want to get back into that playing accounts payable just to keep the hospital alive. Are we going to have to look at other measures to reduce costs?
That's still an open discussion right now, Joel. We're talking about it executive team because we are falling further behind with vendors. It was probably more acute November, December, because typically Metro will not give us subsidy until we reach January. And so that made it a little bit more acute in November and December. They have opened up, I hate to say the spigot, but they always want to be the last dollar in. And they were, I don't know, I think they were mistakenly under the impression that we could just draw CARES Act money from, the sky, even though we couldn't justify the spend. And, that's not something that any finance person is going to do, to violate OIG guidance.
Right.
But we are, our expenses are definitely up. We brought on some physicians in October, really predating October, November, December. Timing would have been better, but we had these in the chute. And then we had, a pandemic that hit just about the time a couple of, significant physician employees came on. Now the volume's coming and the revenue is starting to appear, but the cash isn't there yet. So, I do think that the cash is gonna start following those sort of, I hate to say higher cost, but higher salaried physician and practices in those interventional areas. It's coming. And a large majority of those patients are insured. So we do think it's coming. It's just that particularly contract labor costs and sort of I hate to say that nurses have left the workforce. I don't think they have, but I think a lot of nurses have examined alternate ways of working, maybe traveling or traveling short distances, and it's affecting everybody. It feels like it's an arms race, and nurses are just, and respiratory therapists in some cases, cath lab techs, they're getting offered tremendous amounts of money to go work an hour away or 2 hours away, even though it might be just the same nurses or techs circling Tennessee or close in. But these agencies are making 30% of whatever that $120 is, and they are fanning those flames. And my personal feeling, I think Veronica would agree with me, that there's some that we will probably never do business with again if we can accomplish that, because I think that they have gotten extremely greedy.
Yeah, it is a supply and demand market for sure. I would ask the executive team to strongly consider looking at alternatives, because I don't expect this trend is going to stop anytime soon, and we are going to have to take expense cutting measures, and we need to know what they are sooner than later.
Joel, I mean, many of the expense cutting measures are unfortunately reducing services, because the only way I can reduce in some cases the cost of the nurse staffing, we've got all sorts of alternate plans that HR and chief nurse elders and others have put together to encourage our own staff to take extra shifts. We're paying extra dollars for them. We're doing everything we can within reason. But the only other alternatives in some of those cases are reduce the beds that are staffed, which means divert or close your ICU temporarily until you can get it back down to 7. That doesn't make our physicians happy. It doesn't make our patients happy. And it cuts off a little bit of revenue in the process. But, you know, all we can do really is reduce services in most cases. We are staffing according to our guidelines. It's a really hard call to make right now. Joel, I agree with you. And we look at, believe me, we look at everything that comes through, finance team, and people probably get tired of hearing from us.
Yeah, I understand, but you know, just like they do in the ER, you got to seal the container and keep it from getting worse. So I see that there's going to be a day we're going to have to do something, because I don't think COVID's going to go away fast enough to meet in the middle.
Right. And then, so if I knew that there was going to be this 1.9 billion, I hear that the Biden administration may be sponsoring at some point, if there's a tranche of money that comes available to us, because right now, we've received we're projected to receive about $2 million this year from HRSA, who's paying for uninsured patients who have COVID diagnoses. If we don't have that next year, that's a $2 million hole for patients that right now we wouldn't be paid for if they had something other than COVID. And so there are a lot of things that are moving. This is a very unusual year. I've been doing this a long time. Jerry too. It's a difficult year. And we still have an obligation to provide all the services that we have available to us to patients, regardless of their ability to pay. That makes our job a little tougher than some of the others with, an indigent debt load. If I cut off certain services, I could be cutting off a disproportionate share of insured patients because those without a choice end up having to come to Nashville General.
Okay, just keep working at it.
We are.
Any further discussions? Okay, if no discussions, all ayes.
Aye, Manson.
Aye, Sanders.
Dr. Fagan,
Yes,
there wasn't an initial motion yet.
I'm sorry. Can we get a motion? And a second?
Motion to approve the financials, Joel.
Second, Ranga.
Okay, so no further discussions. Any, well, all ayes, I'm sorry.
Burley, aye.
Slovis, aye.
Manson, aye.
Sanders, aye.
Ranga, aye.
Joel, aye.
Any nays or abstains? Hearing no nays or abstentions, the motion carries. All right, so we're moving on to the board chair's report. Dr. Webb's contract will be up for renewal in July of this year. And so I've appointed a committee to review and make a recommendation for Dr. Webb's contract extension. The committee will consist of Richard Manson, who will serve as the committee chair, Alex Fisher, Frank Stevenson, and Bonnie Slovis. I would like for the committee to meet, come back with a recommendation for the terms of the extension of Dr. Webb's contract at the February 25th Hospital Authority Board meeting. Are there any questions? All right, so Don, can you please turn on your video?
Huh.
I don't see you.
I know. I don't know if I have a video. There we
Okay, I see you. Okay. So I would like to, hi Don, I would like to, look, let me turn on my video. I would like to recognize, I would like to recognize our Hospital Authority Board Secretary, Ms. Dawn Thomas, on her retirement. Today is Dawn's last Hospital Authority Board meeting, and by this time tomorrow, she will be officially retired.
Actually, next Friday, but close.
Okay, so Dawn began her career with the Department of Hospitals in 1988. She was named Executive Assistant to the CEO and Hospital Authority Board Secretary in 2009. During this time, she became a certified health administrative profession, served as president of the Metro Executive Secretaries Association and president of the Tennessee Healthcare Executive Assistance Program. Through her hard work and commitment to Nashville General Hospital and this board, she has played a vital role in our success. On behalf of the Hospital Authority Board, I'd like to present her with a token of our appreciation as she begins her next chapter. Speaking of chapters, Dawn is a published author, so look her up on Amazon. I'm sure you'll see more of her works in the future. Best of luck, Dawn. What's the name of your book?
The greater one, A Testament to the Faithfulness of God.
Wow.
Cool. All right, Dawn. Well, congratulations on your retirement, but we're gonna miss you.
Thank you.
Yeah.
All right, hang on, I'm gonna show y'all.
Yeah, and you're gonna read it for us, right?
Okay. I have to put no, that doesn't work. Has to be on that white background. All right, put it back in there. In recognition of your 33 years of outstanding and dedicated service to Nashville General Hospital, as you retire, may you be proud of all the work that you have done, the person you are, and the difference you have made. Best wishes. Hospital Authority of Metropolitan Nashville in Davidson County.
All right.
Yay, Dawn.
It's been a pleasure working with all of you.
You're really missed. So whoever's gonna replace you is gonna have big shoes to fill. So I don't know if they're on this call, but we're gonna miss you, Dawn.
He hasn't named a replacement yet. I think he's still in denial.
Ah!
That's possible.
And what's surreal?
Look, we'll still be calling you. Don, we got your cell number. We're gonna still be calling you.
Yeah, you have my number too, don't you?
Yeah, and look, don't block me, okay?
No way.
Okay. All right, so we'll move on to the public comment. Are there any public comments at this time? No public comments? All right, so Dr. Webb, do you have any further comments before we adjourn?
I do not. Just want to say before the board, I have appreciated the 6 years that I've spent working with Dawn. She has been excellent, but you know, she's put in 32 years, 32 plus. So I'm happy for her that she's able to move on and do other things with her life. I expect that we'll be seeing a little bit of her from time to time. So congratulations, Dawn.
Yeah, you'll have to come visit, Dawn, just to say hi.
Of course, this has been my family for a very long time.
You're gonna go through withdrawals. All right, so without further ado, hearing no opportunities for discussion, I will entertain a motion and a second for adjournment. All ayes.
Aye.
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 Any nays or abstains? Hearing none, we are adjourned. Thanks, everybody, and have a good night.